Occipital neuralgia and cervicogenic headache both start in the occiput, the base of the skull, and radiate forward to the top of the head. That direction of travel is the single most useful thing to notice. A headache that starts at the back of the head and moves forward is behaving differently from a migraine, and it points the workup at the neck rather than at the head. Let me stay with that for a moment, because it is the part patients can actually use. Where the pain begins and which way it goes is information. Pain that originates at the base of the skull and radiates forward toward the vertex, the top of the head, points toward an occipital or cervical source rather than a primary headache. That does not settle the diagnosis on its own. It changes where you look first. These two conditions get confused with each other, and there is an anatomical reason for it. Because of the intimate relationship between structures based in the occiput and those in the upper cervical region, there is significant overlap between the presentation of cervicogenic headache and occipital neuralgia. They are not the same diagnosis. They share territory, and separating them changes what treatment is indicated. That last point is the reason the diagnostic work is worth doing carefully rather than quickly. So, how is the distinction made? Diagnosis starts with a headache history, assessed against the diagnostic criteria formulated by the International Headache Society. Physical examination then evaluates range of motion of the neck and the presence of tender areas or pressure points. History first, then hands on the neck. Notice that the examination is directed at the cervical spine and the soft tissue around it, not only at the head. Before the injections and the procedures, there is conservative management. Conservative management includes pain education and self-care. It includes analgesic medication. It includes physical therapy, such as reducing secondary muscle tension and improving posture. It includes the use of transcutaneous electrical nerve stimulation, or it includes some combination of those. That list is not filler. Reducing secondary muscle tension and improving posture are named specifically as what the physical therapy component covers, which tells you the neck and the soft tissue around it are being treated, not just the headache. Where secondary muscle tension is a contributor, cervical traction and trigger point injections are relevant, and we have a separate piece on what the evidence supports for trigger points if you want to go deeper on the muscular side of this. Now, injections and procedures. The evidence here is unusually specific about duration, which is genuinely helpful when you are setting expectations. So I want to give you the numbers as they are stated, rather than rounding them into something more impressive. Injection at various anatomical locations with local anesthetic, with or without corticosteroids, can provide pain relief for a short period. A deep cervical plexus block can improve pain for less than 6 months. Those are the stated durations. Short period, less than 6 months. If somebody tells you an injection is going to settle this permanently, that is not what the literature says. In both conditions, an occipital nerve block can provide important diagnostic information and improves pain in some patients, with pulsed radiofrequency providing greater long-term pain control. The diagnostic value is the part worth emphasizing. The block tells you whether the occipital nerve is genuinely involved. That is information you keep, regardless of how long the relief itself lasts. A block that wears off has still answered a question, and the answer shapes what comes next. On the radiofrequency side, radiofrequency ablation of the cervical facet joints can result in improvement lasting over a year. That is a meaningfully different time horizon from the anesthetic blocks. The diagnostic step that precedes it is the medial branch block, which we cover separately. Here is where separating the two conditions pays off, and it is the practical center of this whole discussion. Treatment of cervicogenic headache preferentially consists of radiofrequency treatment of the facet joints. For occipital neuralgia, pulsed radiofrequency of the occipital nerves is indicated, same region of the body. Overlapping symptoms, different target. If the diagnosis is imprecise, the procedure can be aimed at the wrong structure. And if nothing has worked, for refractory occipital neuralgia, occipital nerve stimulation should be considered. Refractory means the reasonable options have been tried and the pain is still there. That is not the end of the road. I want to come back to the migraine question because it is the one people ask first. The point is not that this cannot be a migraine. The point is that pain which starts at the base of the skull and radiates forward to the top of the head points toward an occipital or cervical source rather than a primary headache. And the way you check that is with the International Headache Society criteria, plus an examination of neck movement and tender points. The nerve-directed options that follow from an occipital or cervical diagnosis, nerve blocks, peripheral nerve stimulation, and the broader approach to severe head and neck pain are described on our treatment pages. So let me put the sequence back together. A headache that begins at the base of the skull and travels forward is a headache that deserves a neck examination. The history is assessed against International Headache Society criteria. The exam looks at neck range of motion and tender points. Conservative management covers education, self-care, medication, physical therapy, transcutaneous electrical nerve stimulation, or a combination of those. A diagnostic block can tell you whether the occipital nerve is actually involved, and the procedure that follows depends on which of the two diagnoses you are treating. If you have been carrying a headache like this, and it has been treated as a migraine without much success, the direction of travel is worth mentioning to whoever is evaluating you.